Dear Jerome, dear all, welcome to Rome at the 22nd AME National Congress. AME Scientific Committee and me are happy you are here. Why this meeting with the European Society of Endocrinology? AME would like to share with the European Society its clinical experience with the most eminent European experts in endocrinology. Today, we have a beautiful opportunity to share with our members the most relevant aspects of the recent European Society guidelines of adrenal incidentaloma and in one of the most controversial topics in endocrinology today, the thyroid carcinoma of less than 1 centimeter. Thank you for being here.
Thank you very much, Renato, for starting this session. It's really a grand premiere for the European Society of Endocrinology because it's the first joint session between the two societies, and we have 2 sessions in a row, so that's really great. And as the president of the European Society of Endocrinology, I'm really pleased to see here 2 Italian members of our society who are very active in the society. Maria Cristina Zatelli is the current secretary, and she's a great help, and she drives very well the activity of the society. And Massimo Terzolo, I play a major role, as you will hear during the session, in the development of various guidelines on adrenal disorders. And if you may accept, I will show a few slides about the society, and especially what we are developing in the field of adrenal disorder. So we really want to shape the future of endocrinology in Europe and beyond, and to advance our specialty. We have, as affiliated society, 50 national society, and AME is a strong partner among these 50 societies. We have at present more than 5,100 members, individual members. They have many benefits, and one of them is to have free access to our flagship journal, the European Journal of Endocrinology. Specifically in the field of adrenal and cardiovascular endocrinology, because we are divided in 8 different focus areas, and one is dedicated to adrenal disorders. And they are chaired by 2 leaders, a clinical lead, that's Giuseppe from Norway, and a basic lead, Maria Cristina Zenaro from France, would say almost from Italy. And here are the various activities that we are developing in this field in terms of education, because education is key for us, and this meeting is a great example of an educational activity. We have clinical update meetings planned next year on various adrenal topics, and many of our educational courses, the postgraduate course and the European Congress of Endocrinology, our annual congress, contains specific session on adrenal disorders. Apart from the national society that are affiliated members, we have also a strong association with specialist society that are partner society. And in the field of adrenal disorder, the European Network for the Study of Adrenal Tumors is a very close partner. In terms of clinical care, AME aims clearly at improving clinical care. We are also developing guidelines. And in the field of adrenal disorder, there is the incidentaloma guideline that we are going to hear about today, but we also have developed a guideline on paraganglioma and pheochrocytoma, and another one on adrenal cancer. We have patient advocacy groups that are now members of our society, and we are now developing an adrenal patient forum. And in terms of research, we have recently developed a collaboration with a new partner, the International Fundraising for Research in Congenital Adrenal Hyperplasia, that provide grants for research on CH. So if you are interested in CH, look at this call that is going to be out very soon. And we are developing a research roadmap that will be presented next year. And the adrenal chapter is a very important one in this roadmap. if you have additional questions, the CEO of the European Society, Ellen Gregson, has a booth next to the Secretary of AME, close to this amphitheater, so you can go there and meet Ellen Gregson, that is sitting also in the second row here. Thank you for your attention.
Just 2 words from myself. I am very honored to be here as the Secretary of the European Society of Endocrinology, un membro dell'Associazione Medici Endocrinologi. Grazie per aver avuto fiducia in me. And I'm here also to sensitize you towards some of the activities of the European Society of Endocrinology, some that have been introduced by the President. The first one is the European Hormone Day that will take place on the 24th of April next year. And we invite all the affiliated societies to organize activities around the awareness on the importance of hormones in our daily life. And the other one is, of course, our annual Congress that's in 2024 will be held in Stockholm from the 11th to the 14th of May. The website of the European Society of Endocrinology is already open for registration and abstract submission. And I would like to remind you that there are several grants for basic science, but also for clinical colleagues and nurse grants that will help all the participants to participate to the meeting. And with this, I would like to thank you very much in advance for this joint venture with the European Society of Endocrinology, and welcome the speakers of this symposium. And I'll give the word to Massimo. Thank you very much.
Okay. Good afternoon. I'm very grateful to AME for having invited me to present a case that will serve as an introduction to the lecture of Professor Sahdev on radiology. These are my conflict of interest, and this is the case, a 65-year-old gentleman who has in his history a clear hallmark of a diagnosis of clear cell renal cell carcinoma that was treated with total nephrectomy, meaning removal of both the adrenal and the kidney on the same site. And then during the imaging surveillance, a right adrenal mass was detected in 2007. The radiological report said that was an adrenal adenoma of 22 millimeter, a repeat CT in 2020, because the patient for some years didn't do any surveillance, showed an apparent increase in the size of this mass from 22 to 28, and then in 2023 you see the picture in the slide. The mass was actually 32 millimeter. It was defined as hypodense. No measurement of Hounsfield unit was already performed. It was referred to our center. We did some endocrine screening showing normal aldosterone to renin ratio and normal cortisol following dexamethasone suppression test. We tried to calculate the Hounsfield unit with our software, and since it was in our hands about 20 Hounsfield units, we did a second imaging test, MRI, in August, and you see the results. The mass overall seems an adrenal adenoma because it shows a moderate loss of signal intensity on out-of-phase images compared to in-phase. But there is the unexpected finding of a kidney nodule that is highly suspicious to be a malignant lesion. And so we discussed at the multidisciplinary meeting what to do, because we know that adrenal metastasis from clear cell renal cell cancer may mimic adrenal adenoma, and in this scenario, FDG PET may be of limited utility because this tumor may be less uptaking, have a low uptake of FDG. And so we planned to do at the same time an adrenal biopsy and a renal biopsy. because we have to carefully weigh the risk of surgery, because if we remove adrenal, the patient is rendered adrenal insufficient because the first adrenal was already removed. And if an extensive surgery on the only kidney remaining is done, the patient could have dialysis as a result. And the adrenal biopsy was consistent with a diagnosis of adrenal adenoma, while the renal biopsy confirmed the suspicion of a renal carcinoma. And the further management of the patient was a radiofrequency ablation of the kidney nodule. And so this case presents to Professor Sahdev the challenge of a growing adrenal mass, and the criteria for a significant growth are rather arbitrary. We discussed it a lot when we defined these guidelines in the guidelines. And we have data, these are data from a South Korean study, that yes, it's true that some adrenal incidentaloma during follow-up are growing, but nevertheless, at the end of the day, when they are operated on, pathology reports benign diagnosis in almost any case. So with that, I finished. Thank you, and Professor Sahdev, the podium is yours.
Good afternoon. Thank you very much for inviting me. It's a real honor to be here. And hopefully, I can take you through some cost-effective conversations about what imaging we should be using at the time of presentation, but also, should we be doing any follow-up imaging, and if so, what? So before we delve into cost-effectiveness, which to most people, the first thing you think about is money, and how much does it cost? And that's perfectly acceptable, but you have to evaluate that question in the context of some parameters that you need to set. So before you delve into, is it cost effective, you need to set some parameters about what is the question you're asking. So in the context of an adrenal adenoma, an adrenal incidentaloma, the first and foremost thing that you want to make sure is that you do not miss a malignancy. And only in that context can you really look at cost effectiveness of the tests. We also want to minimize false positives. And the reason for that is we don't want to create an inordinate amount of anxiety in the patients. We don't want to keep having to bring them back for multiple tests. So we ideally want a cost-effective measure that will minimize our false positives but not miss a malignancy. We want to try and keep the shortest diagnostic pathway. For the same reason, you don't want to keep on doing the same thing again and again, because it does introduce a very large amount of psychological anxiety in our patients if we keep bringing them back, not giving them clear answers. So one of the most important things is to keep the pathway short. And also, we need to be able to tell our patients exactly what our performance is going to be and how certain we are of the diagnosis. So having these parameters or responsibilities in mind, you then come on and look at the features that will help you assess what is the most cost-effective test to do. So the easiest one, of course, is the financial unit price. So how much does the test cost? How available is the test? How reproducible is the test? Can different people in different hands, in different countries, in different hospitals come up with the same answer? So that reproducibility actually is very important. We also want a test that will minimize the level of harm that we do to patients. And we need to put them into context of multiple pathways. So in the clinical world, it's never one question. They come to you in different scenarios and different angles, and we want to be able to use our guidelines within those multiple pathways, but come up with the same and consistent answer. So looking first at the unit price, you would have thought that this was an easy question. How much does it cost? Actually, it's a very difficult question because imaging modalities have different prices in different parts of the world. So globally, the same test can cost you a completely different amount of money. Even if you look at different tests, even if you look at the same test, you may be doing that test in a different way. And because you're doing it in a different way, it costs a different amount of money. And that can be in the same country, it can be in the same hospital. So different complexities of the same modality will also affect your cost. And then even if you get past that hurdle, even in the same country with the same modality, you can have different payment systems. So you can be doing the same test exactly the same way, but because you're working in a state system versus an insurance-based system versus a private payment system, the actual reimbursement tariffs are completely different. So again, you can't set your unit price. So it was a difficult question for me to come and say, this is the cheapest test, do it, because there wasn't a clear answer. So I'm actually going to show you two systems, and although the pricing is hugely variant, depending on which country you go to, which reimbursement system you use, which tariffs you apply, there are trends, and the trends are quite consistent. So irrespective of whether you're working in a national system or you're working in the private system, the trends of the costs are actually quite consistent. So looking at the UK national tariffs, which I'm clearly much more familiar with, and the American system, which is the exact opposite, which is the private system, everybody else will sit somewhere in that range. But the trend is the same, as I said. So our non-contrast CT scans are obviously the cheapest modality that we can use. But even in that, you can see the range of variance. It can be almost 10 times the cost of one institution versus another. Adrenal CT, which is the washout CT, because it uses contrast and a diagnostic pathway, costs a little bit more. MRI will go a little bit higher. Then the FDG PET and the adrenal biopsies are the most expensive. Now, adrenal biopsy is a funny one. So you'll notice that the adrenal biopsy tariff, both in the state systems and in the private systems, are actually cheaper than an FDG PET. And the reason for that is because they haven't actually costed the aftercare. And that's a real downside when we come to costing interventional radiology procedures, is because the aftercare is not costed. But the state systems carry that. So the FDG PET, again, is negotiated in whichever hospital you go to, but I've provided you with the range of what the costs look like. So if you were basing yourself just on the unit price, then you can just use this particular table. However, the unit price is not the only question you have to answer, because as a radiologist, I have to look at lots of other options that the patients can have, even if the test is a little bit more expensive. And the three most important for me is availability. Can I actually offer that test to the patients? What's the radiation exposure? Because for young patients, particularly children, and in the teenage years, but also now within the more my age group, we need to start worrying about how much radiation we expose patients, because all of this is cumulative over time. So although a single scan may not appear to be doing much harm, most of us, by the time we're in our 50s and 60s, would have had several investigations done. And all of that is cumulative in risk. So we do need to worry about the amount of radiation exposure that we are giving our patients. And also, does the test, or do the hospitals that we are working with have the expertise to deliver it? So for me, those three questions go pretty much hand in hand in what the cost of the test actually is. Now, CT pretty much wins across the world because it is available, and most of the availability, whether you're looking at the Western world or you're looking at the developmental world, that is pretty much the most available diagnostic test you'll get. The radiation exposure in the Western countries is going down with using CT, and that's because the modern scanners are now using techniques where they actually use iterative reconstruction or low-dose techniques. And that means that we can actually bring down the cumulative dose in our patients. However, it still remains high. So a non-contrast CT is roughly about 3 to 5 millisieverts. And if I put that in context, that is about a 2-year radiation exposure, depending on where you live in the world. Adrenal CT with contrast and a diagnostic imaging reconstruction is about 10 millisieverts, and that again is a hefty dose. if we go back to what that means, that takes up your inherent risk of developing cancers by 1%. Now, that's not a lot, you would say, but if you have cumulative exposures over a lifetime, that adds up. So you can easily find yourself going from a 1% to a 5 to 10%, which is significant medical exposure, very, very quickly. So it still remains a challenge to make sure that you are not exposing patients to too high a radiation exposure. The technical difficulty and expertise, again, important. Non-contrast CT, easy. It is almost completely reproducible. It's very hard to get it to look different from one place to another. They almost always look exactly the same. So this is great because it means it's totally reproducible, it's simple, and it's available. Contrast washout, on the other hand, is highly variable. And when we were looking to put our guidelines together, this was one of the biggest challenges we had, because in those centers that have a lot of experience in adrenal CT, we love it. It really does work. But it's very difficult to prove in the literature because of that huge variation. And the variation exists because people use different times. So they will use 5-minute washout criteria or 10-minute washout criteria or 15-minute washout criteria and everything in between. So actually comparing the studies becomes very difficult. So it's got a huge amount of variability, and therefore the reproducibility falls. It's also technically more difficult to do. It requires contrast, and therefore you always need to have, in any hospital you work, medical personnel available just in case there is a contrast reaction in the patient. And again, reading the test is difficult and needs a more technical person to know what they're doing. So the region of interest needs to be in the correct place. It needs to be the right size of the region of interest. So a little bit more difficult to do than just the non-contrast CT. MRI's availability is definitely better than it was 5 to 10 years ago across the world. It is now pretty much equivalent to CT in the Western world and getting better in the developing world. And of course, its greatest trump card is that it has no radiation exposure involved. So that makes it really suitable for the use in children, in pregnant women, and any other reason where you can't use a CT or contrast in CT. It has got excellent reproducibility again. And again, because it's a non-contrast study, it's technically easy to do, and the reading is reproducible. I put claustrophobic patients in here in this group because there is still a category of patients that we can't use this for. Again, the new scanners coming in are bigger bores, so they are wider, fatter scanners effectively, and we can use that in more patients than we used to before. PET-CT, very popular at the moment and growing in popularity, particularly in Europe and the United States. Less popular in the UK and in the developing world. Our availability is a lot less than it is in Europe and the USA as well. The biggest problem with FDG is the dose. The radiation dose is enormous. It is about 5 times the dose of a non-contrast CT, and it's about 2.5 times the contrast dose of a CT washout study. So its dose exposure stays very high. Even with the newer scanners that are coming in, the dose has not significantly gone down. It's also not as reproducible as it was previously thought. And the reason for that is the variation in the injection dose that the patients are given. So the FDG tracer can be given in different doses. And the SUV measurements that we use can also be interpreted differently. So the variability and the reproducibility in FDG PET is also quite high. And you, of course, need a lot of expertise in reading a PET scan. So you not only need the radiologists, but you also need the PET technologists to be there. So this is quite intensive in dose, not very good in reproducibility, and definitely very expert intensive. Adrenal biopsy, I've put it in there for completeness. However, its availability is limited. Most centers will need an interventional consultant to do this, and it introduces a clinical risk which the others don't have. Most of CT biopsies are CT-based done. The adrenal biopsies are CT-based, and therefore it carries the radiation dose of a CT scan. So it's about 10 millisieverts if you're lucky, and even higher if the biopsy is difficult. And of course, you always need an interventional radiologist or someone who has got a lot of expertise in doing this. So using these parameters, what would you pick first? So without question, the non-contrast CT wins on all of these parameters. MR comes in second, over and above that of CT washout, purely because of its reproducibility and its lack of radiation. Those two are really pretty much the reason for choosing MR over CT. And FDG PET, again, based on all the issues I have raised, would come below a CT washout. One thing that I haven't mentioned in this discussion at all so far is what is the pretest probability of the disease that you're looking for? Because clearly, all of these imaging modalities are only useful if you know what the question you're asking is. So the pretest probability is actually very important in deciding how you place your choice of imaging modality. And I'm going to try and talk this through over the guidelines that we've developed. So we know one of the things that we have said is that if you find an incidentaloma and it's homogeneous, bring them back, do a pre-contrast CT. And the choice of a pre-contrast CT is clear, as I've just explained. And we know that the performance of pre-contrast CT is extremely good. I'm not going to talk too much about this because I know this is going to be covered a little bit later. But essentially what it means is, in a single step, we have answered the question because we know about 80% of our incidentalomas are going to be in this benign category. So one single step, a very affordable test, it's a very available test, it's very reproducible, and we can apply it all over the world. So if you're going to develop guidelines, you want to have the maximum audience you can capture. And this test pretty much ticks all of those boxes. It gets more difficult with the rest of the lesions, and I think we spent several days and days and days talking about these ones. But this is where you need to start thinking and putting all of those issues that we have raised and the pretest probability of the disease that you're about to see. So the next category that we had was small lesions, a little bit denser. So these are between 11 and 20, so they're not ticking that box of a benign lesion yet. But the pretest probability of malignant disease in this group is extremely low. So yet again, you have to pretty much keep to the context of confirming that this is a benign lesion and not necessarily working with the malignant modalities first. So again, what would you choose? Would you choose an adrenal CT? Would you choose MRI? Or would you choose FDG PET? Now, having said that the malignancy rate in this group is extremely small, I think we can discount FDG PET in this group. That took a lot of discussion in the guideline panel. But I think the top two choices here are adrenal CT and MR. And actually, there is very little evidence in the literature to be able to separate whether you pick adrenal CT or whether you pick MRI. And that's because the performance of all of this is based on small studies, and even when you do systematic reviews, you don't have great numbers. But essentially, the performance of the two tests is very comparable. So it's left then to the user to decide what have you got that is available in your institution, what is it that you have best expertise in, and then those two aspects become your cost effectiveness measure, and you can use one or the other, because as a unit price, there is not much between them. So this is just an example of the sort of lesions that we would be talking about. Remember, these are homogeneous lesions, and the first group that we've looked at, the first row just shows you a contrast washout CT. This is a lesion that is a little bit above 10 Hounsfield units, but below 20, so very likely to be benign. And what we want to be able to demonstrate that it has other characteristics of a benign lesion. And clearly this lesion has a contrast washout at 15 minutes of 80%. That's consistent with an adenoma, and we really wouldn't need to do any more than that. The lesion below is exactly the opposite. Although it's homogeneous, it has no loss of signal intensity on a chemical shift imaging, so this was not considered to be a benign lesion at the time. It was resected, and this was a benign pheochromocytoma. The next category, again, remember that the risk of malignancy is now going up. So again, your pretest probability of finding a malignant lesion is increasing. So if we look at the first group, which is, again, a homogeneous lesion, but it's bigger this time. So this is now over 4 centimeters, and it doesn't fulfill the criteria of having less than 10 Hounsfield units. So it's homogeneous, but big and dense. So what do you do there? So because it's homogeneous, you can use another test in cross-sectional imaging. So you can either pick an adrenal or washout CT, or you can do MR. Now, this category, my personal preference would be to do an MRI scan. And the logic for me is because even in this category, there are still lesions that are actually adenomas that have some lipid in them. And MR, we know, has slightly better sensitivity than CT to detect that little bit of lipid. So you can still pick out some of the lesions with lipid in them in this category, and then you would be clear that this was a lipid poor adenoma, but it was lipid, but it does have lipid in it. You would not be criticized for using a contrast washout, and it would be just fine. The next group, which is a homogeneous lesion, but it is dense, and it's denser than 20 Hounsfield units now. So you're now really entering the tiger land. So now these lesions are really got high probability of being malignant. So you now need to know whether you will do either a washout or a follow-up or a PET CT, because the incidence of malignancy in this group now is about 10%. So you've got to make sure you don't lose that 10%. Then, of course, you've got the heterogeneous group, and actually nothing works for the heterogeneous group in imaging. So as soon as you have a heterogeneous lesion, there's no point in doing any further MR or CT, because it's not going to take you any further. Your choices here are ACT, take it out, or confirm that it's malignant lesion with an FDG PET. So this is the most variable group, and this is the one that you really do need to have all your parameters to try and work out what works best for the patient and for your institution. The last group is, again, an easy group in a way, because these have a very high malignancy rate on them. So about a quarter of these lesions will be malignant. So actually, that pretty much overrides all your other options. So you now need to treat this as a malignant lesion until proven otherwise. And so the recommendations is you either take it out. If for some reason you can't take it out because either the patient doesn't want to take it out or they're not fit enough to take it out, then you can confirm malignancy and consider other options within them. So this is an example of that sort of heterogeneous lesion. So it was an incidental lesion that was picked up. It was on a post-contrast CT. There's no point in bringing this back for a pre-contrast CT. It's not going to add any information. I don't know why we did an MR, but we did, and there's just still shows you it's a heterogeneous mass. Still can't tell you what it is. So you have to take this one out. So I'm going to stop now, because this was a cost-effective lecture based on a radiologist. So I apologize to the health economics people in the room. We do need to think of other things other than just the unit price of the test. The test performance is important, its availability, its reproducibility, and the experts to read it are all important. And if you don't have any of those, then the cost of the test is quite irrelevant. And then most importantly of all, put it in context. We need to know what the pretest probability of what you're looking for is captured by the imaging modality itself. Thank you.
Okay, we'll have a global discussion at the end. Now there is the second case that serves as an introduction to the lecture of Professor Reimondo. And this is the story of a 67-year-old lady with an incidental diagnosis of bilateral adrenal masses, 44 millimeter on one side, 29 on the other side, benign characteristic, unremarkable family and personal history, active smoker, no treatment with drugs. Physical examination, no sign of Cushing syndrome. The patient is actually underweight. Blood pressure is low normal. And also in the routine biochemistry, there is nothing remarkable. We did the hormone workup, and we were in some way surprised by finding this high level of cortisol following the 1 milligram dexamethasone suppression test. You see 14.2 milligram deciliter, while the normal is less than 1.8, and plasma CTH was completely suppressed. So we repeated the 1 milligram dexamethasone suppression test, and again it went back to be very high. And we did also additional tests. You see 24-hour urinary free cortisol, borderline elevated, midnight salivary cortisol, borderline elevated in 3 different occasions. DHEAS is low for the age range. And we also completed the clinical evaluation looking for potential comorbidities, but the oral glucose tolerance test returned back normal, while at DEXA we found a reduction, a significant reduction in the lumbar T-score and also in the femoral neck T-score, and at spin X-ray we found a more than 20% reduction in the height of D7. So we have osteoporosis and vertebral fracture in a patient with bilateral adrenal masses and mild autonomous cortisol secretion, or MAX, as it is now called, this condition, following the guidelines. We tried a course of medical treatment with ketoconazole, 200 milligrams twice a day, and also we started alendronate and calcium vitamin D supplementation that was stopped, biphosphonate, and continued only calcium and vitamin D. And this, this is the follow-up for the endocrine test. You see that urinary free cortisol was improved, and also midnight salivary cortisol, while CTH remained suppressed. Routine biochemistry did not change at all, and after 2 years we had some improvement in the T-score. So the case posed the challenge of bilateral adrenal masses with MAX, and there is also some discrepancy between the level of the alteration in the hormonal test and the few physical signs that we see, and we have only impaired bone health as the only comorbidity in this patient, and in the guidelines impaired bone health was considered the comorbidity less tied to autonomous cortisol secretion. And so I guess that Giuseppe will comment on this aspect. And also, since I know Giuseppe very well, I will try to get the most from him, and also asking some word on the treatment of this difficult case. So thank you, and Giuseppe, please come to the podium.
Thank you, Massimo, for the introduction, and I would like to thank for this, and I'm very honored to be part of this joint meeting between the AME and the European Society of Endocrinology. And I would like only also to have some discussion, not only to cost-effective of biochemical evaluation in the diagnosis and follow-up, but since biochemistry has a consequence on treatment, in some issue, I would like to discuss with you some consequences on treatment. And the other point is that I would like to compare the previous guidelines and the actual guidelines in terms of cost-effective consequences. And so, these are my conflict of interest, and which is the meaning of cost-effective evaluation has been deeply introduced by Professor Sahdev, and I don't want to repeat some important issue that she has raised, but I think that we have to define our clinical question. And our clinical question is the primary concern is to determine whether the adrenal tumor is hormonally active. But not only, we have to consider also age, gender, and frailty of the patient. And obviously, depending on this finding, the patient may require follow-up, may require medical treatment, surgical treatment, or simply observation. Although the ultimate cost-effective would also depend on specific clinical context and the availability of resources, the goal is to give to our patient an appropriate and timely care based on the functional status and the tumor type. And so we have not only to consider the cost per se, but also the consequences in terms of appropriate care of our patient. And we start from the first point. We have to identify the most relevant test and estimate the clinical impact. There is not a main difference from the first evaluation in 2016, but in this new version of the guidelines, we have a stronger recommendation for the use of 1 milligram overnight dexamethasone suppression test, and an important addition, since the frail patient with a limited life expectancy, this test may not be warranted. And so there is a restriction to the evaluation of our patient other than an increased level of evidence. And this is the first point that we have that could be cost effective. And the other point is that we have similar consideration than in the previous guidelines for the detection of primary ALDO that should be reserved for patients with hypertension and unexplained hypokalemia. But for pheochromocytoma is considered not only the need to exclude a pheochromocytoma, but also the type of lesion, since a lesion has only a not typical type and radiological characteristics for a benign adenoma. If we have a non-typical adenoma, we can proceed for the evaluation for metanephrine or non-metanephrine. And this is an important point, since the literature have demonstrated that the possibility to have a pheochromocytoma in patients with very typical radiological lesion is near to zero. And so also in this subset of patients we have a restriction in the evaluation. But the most important point is, as usual, the evaluation of the hypercortisolism in our patient with adrenal adenoma or adrenal lesion. And it has been definitively introduced the concept of the mild autonomous cortisol secretion. And not only, in the previous guidelines we have different classification in a possible autonomous cortisol secretion and then also in autonomous cortisol secretion that could complicate maybe the evaluation of our patient. But now the problem, and it has been solved, and we have now a different concept, that the hypercortisolism is a continuum, and the increased risk depend on this continuum increase of the level of degree of hypercortisolism. And so we have some consequences. All the patients with levels of cortisol levels higher than 1.8 microgram per deciliter should be considered as max, but we have to this implies, and this is important also to consider, that it is better also to perform an ACTH evaluation to distinguish patient with ACTH dependent or ACTH independent. And also the problem that is being raised by the clinical case, that is the repetition of the dexamethasone suppression test, always, or at least in all patients that should go under surgical treatment. Is this approach cost-effective? I don't want to discuss all these points, but when we compare these two visions and these two versions, it seems that the newest version seems to be more cost-effective due to its simplicity and clarity in guiding clinical practice. The previous was informative, but may lead to a variability in interpretation and potentially may require additional tests. And so it seems that the new version is more cost-effective. But when we have to evaluate our patient, the clinical decision-making is driven not only by the cortisol excess, it is important, it's very important as we know, but also by the age and the general condition of our patient. And depending on this finding, we have to ensure that patient with adrenal incidentaloma receive appropriate and timely care. This is the most important point. And so only some point on the treatment, since in the new guidelines there is a major modification from the previous ones. And as you can see here in the 2016 version, there was a suggestion on an individualized approach of patient with autonomous cortisol secretion, yes, considering also age, degree of cortisol, and the general health. But now is more complex and more detailed, since has been introduced a recommendation, the strengthening of this statement is increased, and there is a recommendation that the option of surgery with the patient should be discussed always with our patient, obviously in addition to relevant comorbidities in unilateral adrenal masses. And the other point is that we have also to observe the degree and the persistence of hypercortisolism and the severity of comorbidities that are additional factors that we have to consider, and the institution of a multidisciplinary group that should have a major competence in the individualized approach. And so there are some pros and cons in this approach. Only few points that I would like to underline. The previous guideline, it seems to avoid some unnecessary surgery, since several factors are included, are considered, but the suggestions is more flexible than a definitive recommendation, and so it may lead to a variation in practice and decision making. On the other hand, we have a more stronger recommendation in the newest version to discuss surgery with patient, the involvement of a multidisciplinary group ensure to the patient a high level of expertise and consideration of all relevant factors. On the other hand, we could have the risk to increase some surgical treatment that potentially increase the health care cost. And in summary, in this situation, it is more questionable, and we can discuss on this more, since it depends on the availability of the healthcare resources, also the availability of a multidisciplinary group that could influence the final choice for the patient. And so it is more difficult to distinguish between the two proposals. But we have also patients that do not undergo adrenalectomy. And we have to follow this patient, and it is a major point, this, in our clinical practice. And the first recommendation that has been increased in this level is that against the repetition of the hormonal workup in patients whose results are within the reference of range, and so that are normal at the first evaluation. Although we have also to consider here that if patients appear to have a worsening comorbidities, and then we have to repeat also our evaluation. And I would like to insist on this major and very important modification, since guide our clinical practice. The first point is that a recommendation has been produced by the panel, and that recommend only an annual reassessment of comorbidities in patients with MACs that are potentially attributed to the cortisol. But on the other hand, there is a suggestion that it is very important, as they suggest to discharge from specialized center and to continue the follow-up of comorbidities in the primary health care system. And this is another important point. Usually we continue to evaluate this patient, but this is an opportunity, this is a possibility. Finally, if the comorbidities develop or worsen during the time, the patient should refer again to endocrinologist. But this approach is, it seems very cost-effective, since the primary care provides a usual comorbidities evaluation, and this approach could potentially optimize our resources, referring the patient to the endocrinology only if comorbidities arise, appear, or worsen during the time. It depends on the organization. Each nation have different evaluation, different healthcare organization, but it seems an advance in our evaluation of the patient. And the last part of my talk is dedicated to this specific focus on patients with bilateral adrenal incidentalomas that derive from the clinical case that has been presented by Massimo. And which is the first statement? The first statement is that it is recommended that the patient with bilateral adrenal incidentaloma should undergo either clinical or hormonal assessment that are similar, identical to the patient with unilateral lesion. However, the patient with bilateral adrenal incidentaloma are not a unique, a single disease. At the best of our knowledge, we can stratify, and the panel has stratified this patient in 4 different types and 4 different possibilities. The first one is the possibility to have a bilateral adrenal hyperplasia with multiple nodules. The other type are the bilateral nodule adrenal adenomas. And then again, two similar, morphological similar, but not adenoma-like adrenal masses, such as, for example, metastasis. Or, at the end, two morphological different adrenal masses, but are benign lesions, such as pheochromocytoma or leach adenoma. Why it is important to stratify the patient in these four different types? It is important since the consequences are relevant for the evaluation of our patient. If we have a bilateral hyperplasia, if a congenital adrenal hyperplasia is suspected, we have to consider also, other than the other tests that we have considered for the unilateral lesion, the measurement of the basal 17-hydroxyprogesterone to the diagnosis of congenital adrenal hyperplasia. But not only, in the presence of multiple nodules and a CTH-independent MAX, also we have the availability, not in all centers and not for all patients, of a genetic testing for the germline pathogenetic ARM-C5 variants that should be offered for the patient. And finally, in infiltrative masses, we have different need. For example, we have to exclude adrenal insufficiency. And so our biochemical evaluation is different from another lesion. And then this approach that is more complex due to the different type of adrenal lesion, although started with the suggestion of an individualized specific treatment, also is suggested to exclude a bilateral adrenalectomy. This is another important point. More generic and less specific was the previous suggestion that only report the same recommendation for the unilateral lesion. And so, for all this reason, it seems that this approach is more comprehensive, is more detailed. It is true that increased the level of complexity, but it also increases the improvement of the patient outcome if a patient is well identified in his typical lesion. And so this could justify the additional cost associated to this personalized approach. And then I would like to come back to the clinical case. I would like only to remind to you that she was a 67-year-old lady who had not any medical treatment, with the absence of typical signs of Cushing's syndrome. And Massimo underlined the problem that although there was no any clinical signs, the dexamethasone suppression test was unexpectedly higher than normal and was repeated. And also were added other hormonal evaluation, in this case is right to proceed on this. And also in this case the levels was at the limit, higher limit of normality or slightly higher than normality. And so the first discussion, the first point is that we have also to consider when there is this discrepancy with the clinic or with other hormonal tests, that the patient could use some drugs that may potentially interfere with the dexamethasone metabolism. This is the first point. This is not the case for our patient, but in some other patient it is important to evaluate this point. And the other point is that has not been discussed, and it is still discussed, it is the evaluation of the dexamethasone circulating levels that it is not widely available, but in some selected cases should be cost effective since reduced the false positive test. So we have, as a summary, this patient that has a bilateral adrenal masses and MAX, osteoporosis, vertebral fractures, and without any other complication. And some question and answers that I've tried to give from this clinical case. The first one is, was requested the repeated DST? I think yes. And we can also discuss if, since there was a discrepancy with the clinic, and we can also discuss if dexamethasone circulating level should be added in this situation. The second point is, has the patient a Cushing syndrome? No, the diagnosis is clinical. We have a patient with an hypercortisolism, but without any sign of Cushing syndrome. But this hypercortisolism should be treated. This is another point. Yes, it should be treated, since also in this meta-analysis that derive from the panel work and that is very recently published on the European Journal of Endocrinology, it is demonstrated that this patient should potentially have an increased risk of mortality, in particular when you consider patient with higher level, higher degree of hypercortisolism, and the same figure is demonstrated also for osteoporosis and the effect to avoid and to prevent future fractures. And the last one is provocative, that which is the treatment of choice in this patient. I'm sorry, but it requires a new plenary session. And so I finally would like to thank you for attention. Our small but lively adrenal group and the two society, AME and the European Society of Endocrinology, for the fruitful collaboration. Thank you very much.
So thank you very much for these two excellent presentations after these two very illustrative clinical cases that are now open for discussion. So maybe the two speakers, you could join us here. And if there is a microphone in the room, no? Just, okay. Maybe I could just start. The first case, so that's for the radiologist, it was diagnosed as a benign adenoma at the first CT scan 15 years before, I think. Something
Yes,
like
that's
that.
right.
Then we saw that it was growing, which was a matter of worry. But would you recommend, apart from the fact that this case is special because he had, in fact, kidney cancer, so that's why he was monitored. But today, with the current recommendation, what would you advise as a radiological follow-up?
Yep, no. So one of the comments I was going to make on this case was I was surprised that the MDT's decision was to biopsy that, not the adrenal, for two reasons. One, the growth rate of that adrenal, yes, it was growing, but we know adenomas are tumours. They will grow as well. And this had grown only by 1 centimetre over 16 years. That is not really significant growth. And that would be perfectly consistent with an adenoma. There's also an MRI scan that very clearly even shows visual signal drops. So there were two aspects here that showed that this was going to be a benign lesion. So actually, my MDT's recommendation would have been strongly not to biopsy that lesion. I would have left it alone.
question from the participant? I'm sure there are questions. These are two very so common situations that we see every day in our clinics. Anton Luger here.
This is a question to the second presentation. Is there any special reason that in the list of the anticonvulsants you mentioned two, but is there a reason that carbamazepine was not mentioned, which is still widely used and gives false positive?
It's true. It was only an example that was previously published, but we have also many other drugs that can influence the dexamethasone level. So it is not a specific reason.
I can ask many questions, but I'm sure not the only one here. And a second question from Anton, while the microphone is coming back. You mentioned that's for the second case. It's a bilateral incidentaloma. The more carefully we look at the incidentaloma, the more often now we found that they are bilateral, in fact. So the question is about how to be sure that this is ACTH independent. In this case, ACTH was completely suppressed. But probably this is the sign that she clearly had hypercorticism, as you conclude at the end. But most often, this is not that clear. So how do you sort out, especially in routine clinical practice, in ACTH assays that is done in private lab in the city, how do you handle that? And what do you recommend for that?
It's very difficult to answer to this gray zone that is frequent in our clinical practice. When there are some not clear results, that is usual, and also when there are some differences due to the preclinical problem, since sometimes the ACTH is very low and sometimes it's not so low, but the dosage is good. Sometimes we perform, or we performed until the availability, the CRH test in this patient to evaluate also the response of ACTH and cortisol. And so sometimes we have performed this because we have always to consider that a pituitary lesion should be present in our patient. We have several patients with this situation.
That's right. So CRH is not available anymore.
I'm not aware.
This is really something our two society should do some lobbying effort to CRH.
It's very important.
Even though this is where situation, this is really
a very problem.
So Anton Luger, second question.
Sorry. Regarding the medical treatment of hypercortisolism in the case of bilateral masses, do you have any preference for any drug? I mean, with osilotrostat, there is now, all of them have considerable side effects. So what would you choose as first-line medical therapy?
We have to open a new plenary section also on this treatment. It depends on the availability of the drug. It is a very important question. This, and so thank you for your question. It is not so easy to have an answer since we have a patient without a Cushing syndrome, and so it is an off-label indication. But it depends on the levels and only the availability of the drugs. And also the type of patient, if it is a female, if it is a male. If it is a female, it seems better to use ketoconazole, for example, or usually I prefer low doses of metirapone or osilodrostat if possible. And there are some data that we also are trying to evaluate to use these drugs in the later part of the day, in the evening, to reduce and to reactivate the circadian rhythm. And so it depends on the patient and on the availability of the drugs. In this case, was chosen this ketoconazole, but Massimo can respond.
No, we used ketoconazole because the cases some years ago, osilodrostat was not available, and the choice was between ketoconazole and metirapone. We preferred ketoconazole because the patient didn't have Cushing, so we were in some way anxious that metirapone was a bit too strong because it has a more rapid effect on cortisol, so we don't want to have hypoadrenalism on board. So our choice was on ketoconazole, but I mean, it is highly debatable what is the best drug, and possibly, as Giuseppe said, we have again to tailor any drug to a specific patient.
I would like just to add a comment that may be discussed by the speakers, that for the first time a guideline is clearly taking into consideration the opinion of the patient. And I think this is very important because we are here discussing about what to do, but without the host. So it is really very important to understand what is the perspective of the patient, what is in order to make him or her to make the best decision and to for the sake of his or her health. So I was wondering whether you could suggest a strategy to communicate the diagnosis and to have a very good discussion and perspective with the patient, because this is the first time.
Giuseppe.
So, oh, sorry. I was just going to say, in taking into consideration the patient's opinion, one of the things that we've started doing is having patient groups. And so when we are actually developing pathways, we have a member of the public with the disease in question as part of the patient pathway development group. It's been a real eye-opener, but one of the things that they really don't like is to keep coming back. So I think it pretty much underlines the fact that whatever we're going to do, we ought to try and shorten the pathways as much as possible, avoid repetition. In my experience, the patients don't seem to mind having a cluster of tests in the beginning to be able to come up with a definite strategy. But what they don't like is uncertainty, to be sent away for 6 months, not knowing. I mean, in the adrenal world, you may have an adenoma, which means nothing, but you could also have an ACC, which will kill you. That is just not nice to live with for 6 months, 7 months, 8 months that we want to follow them up for. So I think the learning point for me was do everything you can in the beginning and limit that follow-up to as much as possible. Thank you.
Another important point that is clearly stated in the new guidelines are the categories of patients to whom you have to avoid, to insist to have several hormonal evaluations, such as aged patient or frail patient, and this is also very important. We know clinical expect this, but it is clearly stated, but this is a joint consequence.
Giuseppe, the question is the same picture, but with an adrenal lesion. Could you suggest in such a situation surgical treatment? Could you suggest?
A multidisciplinary evaluation that is recommended. The same patient with one lesion. But by the way, I think in this case, surgical treatment.
Thank you.
If I have a patient with increased levels of cortisol after DST, but with normal levels of SCTH, it could be useful to control SCTH levels during the follow-up to evaluate if the levels get suppressed. So another point to evaluate the stage of hypercortisolism.
It is not declared and it is not stated, but I think that when we reconsider the cortisol levels, I think that the first step is to reevaluate, if needed, the cortisol levels, and if confirmed, also to add ACTH levels. There are also some initial experience on the evaluation of ACTH and cortisol after dexamethasone suppression test to consider and to evaluate this. And another point is the variation of the cortisol level during the time that we are searching to evaluate by a protocol, an NSAT protocol by now. And so we will, I hope, some answer in the next year.
If I can add, we have a lot of discussion between the members of the panel about if other tests are to be done apart from DST and the CTH. There was a big discussion, and actually the practice varied a lot between us. So some of us are currently doing more tests and other less tests. But at the end, we tried to minimize the number of tests that are to be done, also to minimize the cost, also to minimize the uncertainty, because the more tests you do, the more you can get some altered results that cause anxiety in both patients and doctors. And so there was no clear recommendation. I mean, it is usual to see some, elevation in cortisol following DST, and ACTH is normal, so this is not surprising. We did not recommend specifically to follow ACTH. Okay, it depends on the comorbidity. We try to focus on comorbidities. If the patient has comorbidities, okay, you can think at surgery, and okay, if you want to go to surgery, by sure you should be in some way sure that it's not a pituitary Cushing with an adrenal mass that happens. But if the patient has no clear comorbidities or comorbidities that are stable or are expected, we didn't recommend to measure ACTH or repeat DST. So we tried to give low-cost recommendation. Downgrade, yes.
How can you exclude a cyclic hypercortisolism in a patient such as this? That in my experience is very frequent. And I am very perplexed in front of the clinical behavior of this case, since, in my opinion, this patient has a mild hypercortisolism. And the clinical symptoms could be very mild in such patient. Now, in our daily practice, we see a lot of patients with biochemical diagnosis without a clinical symptom. And so the problem that this patient poses are a lot. And one point more, in these last guidelines, the cutoff of cortisol level after dexamethasone is still 1.8, is better than 5.8. But now we are faced with a new assessment of cortisol, and so 1.8 is an old one cutoff as compared to the new cutoff we could use.
Yeah, I answer to the second question first. Obviously, we should write guidelines based on the evidence that we have, and the evidence that we have now is on 1.8. We are all aware that possibly in the future we should lower this cutoff, because if we use extensively liquid gas chromatography, also mass spec, this assays measure lower level of cortisol compared to the old assays. So in the future, this will be true, but for now we should use the literature that we have, the evidence that we have. This possibly explains why some non-functional tumors have comorbidities, because actually they are not non-functioning. Coming back to the case, yes, it's possible a cyclicity. A cyclicity is but again, we try to be very clinical, very practical, and very clinically oriented. So first, look at the comorbidities, and second, look at the cyclicity. This is interesting from a pathophysiological point of view, but for clinical management, what is really important is the comorbidity. And then clearly there is an overlap between max and mild Cushing. That could be, and this could not be solved by any guidelines, I guess.
One more question. I have a question for the radiologist. So, if I suspect a FEO, what about the CT scan? What is the Ansfeld number that makes me to think about a FEO?
So the diagnosis of FEO will be biochemical. And on imaging, they mimic everything. So you can have very benign looking pheochromocytomas like the one I showed you, and you can have very aggressive looking masses as well, which will also be pheochromocytomas. So as a radiologist, I almost need you to tell me that you're suspecting a pheo, and then I go hunting for one. The starting point will not be picking up the lesion as a pheo, because they can look like anything.
Thank you for your excellent update on the topic. I have a question for Professor Terzolo and Professor Reimondo. Little concerns about the management of osteoporosis in the second patient, 67 lady. She was diagnosed with a secondary form of osteoporosis, mild to severe osteoporosis, complicated by a vertebral fracture. So I understand that the patient refused the treatment with bisphosphonates. The question is it ketoconazole enough to prevent the progression of osteoporosis, or there was a need for another anti-resorptive agents or teriparatide? Thank you.
Said that, but for the sake of saving time, I mean, this is not a plenary lecture on secondary osteoporosis, so we didn't put all these things.
Briefly, you can adapt and you can use all the drugs that you are available. Also, in this case, that was it was some years ago. Some drugs were not available. Not only ketoconazole is enough, but you have to manage the patient in the two directions.
Okay, thank you to all. And now the session is stopped, and we come back in 15 minutes after coffee break. Thank you to all.